This is our second podcast in the series on the respiratory system. Here we're going to talk about the conducting organs to start with. And so the conducting organs basically are organs that from the nasal cavity, so the nasal cavity itself, the nasopharynx, oropharynx, larynx, trachea, bronchi, and even the bronchioles that are in the lungs. Point I'd like to make, the basal lamina in the conducting airways tends to be relatively thick, and it's rich in elastic fibers. The respiratory structures, which we'll talk about later, would be those structures that begin at the respiratory bronchioles and end in the alveoli, and the walls in the alveoli contain abundant elastic fibers. Now, you might imagine that elastic fibers are going to be abundant in many regions of the respiratory tract because as there's inhalation and expiration, these organs have to expand and contract, and a major function of the elastic fibers is to provide that elasticity for these organs to function during inhalation and expiration. Now, as we talked about, there are some inherent problems with the respiratory tract. We have a cleaning problem, a patency problem, and the need to have a large surface area for gas exchange, but this has to operate at a low pressure. What I'd like to talk about first are the mechanisms for cleaning, and let's talk about this in the nasal cavity first. And some of this you will know from your gross anatomy, but for example, the vestibule in the nasal cavity is lined by a stratified squamous epithelium, but as you know, there are fairly large nasal hairs associated with that epithelium, and you know that these nasal hairs can trap large particulate materials. Now, there's a warm, moist surface that's provided by the mixed gland secretions and a rich blood supply in the nasal mucosa. This allows gases to dissolve in the moist surface layer. You know that there's turbulence of air, and that has increased because of the nasal conchae, and the nasal conchae are lined by respiratory epithelium. The nasal blood supply is characterized by a series of arcading arterioles and venous swell bodies, and this blood supply allows the nasal cavity to warm the air. It helps to have the air moist, and it plays a role in cleaning the air from the point of view of the secretions that are involved in the nasal area. And this is just a cartoon, and it's just showing the respiratory mucosal cells in the nasal area. Here's the histological view. Look at the very large blood supply with these large expanded venous areas, sometimes called venous swell bodies. And then the cartoon on the top just reminds you that warmer air holds more moisture. So you can see air at 73 degrees Fahrenheit might hold a moisture content of something like 40% relative humidity, but if that air is warmed to 90 degrees Fahrenheit, it can have a 98% relative humidity. So that's very important for keeping this epithelial surface moist. Here you can see the respiratory epithelium. You can see these Bowman's glands, which secrete the serous substance. Here are some of these large venous swell bodies. There's a profile here. Here are some profiles of blood vessels. Another blood vessel here, another blood vessel here. So the point, this submucosal area in the nasal cavity has a very rich blood supply as well as these Bowman's glands for secretion. Pharynx obviously is a passage for air and food. The nasal pharynx connects the nasal cavity to the larynx. That's lined by a typical ciliated pseudostratified columnar epithelium, the so-called respiratory epithelium. As you know, the oropharynx connects the oral cavity to the esophagus. That's lined by a stratified squamous epithelium. And from the point of view of the respiratory system, the function of the pharynx is essentially a resonating chamber for the organs of speech. The larynx has irregularly shaped cartilage plates. You should remember that from your anatomy. And these cartilage plates consist of hyaline cartilage primarily, but there are regions of elastic cartilage in the larynx as well. There are clearly the vocal cords or vocal folds, which function for pitch and phonation as we speak. There's the vocalis muscle, which is important in speech. There's the intrinsic laryngeal muscle, which is important for swallowing. swallowing, and these two muscles are skeletal muscle. And then there are structures called the ventricular folds or false vocal cords. These are very important for resonance for speech production. Now, the vocal cords are covered by a stratified squamous epithelium, and it's thought that this stratified squamous protects the mucosal surface on the vocal cords from abrasion that would occur from the rapidly moving airstream that passes over those as we try to phonate or speak. The remainder of the larynx is covered by a typical respiratory epithelium. This is a very nice image. This is a very low power image of areas of the larynx, and so you can see the area where there'd be the vocal folds or vocal cords. You can clearly see the vocalis muscle. These ventricular folds or false vocal folds are also shown. And here on the image on the bottom is just a higher power view of the vocal fold. You can see it's covered by a stratified squamous epithelium. There's dense connective tissue underlying that epithelium and the vocal ligament, and then you can see the epithelium in the ventricular folds, a typical respiratory epithelium. But note that in some areas of these false folds you get a stratified squamous epithelium, and this is something that's fairly common. It's called a squamous cell metaplasia. That is, cells that give rise to the respiratory epithelium can also give rise to a stratified squamous epithelium. And so you may think if there's like some continued abrasions, maybe you're a cigarette smoker, maybe you live in a highly polluted area, or you cough a lot, some of this respiratory epithelium will transform to the stratified squamous epithelium just to provide a little more protection on the mucosal surface. This is a normal adaptive response to the environment. You can also see in this ventricular area numerous mucus glands, and you can see numerous lymphatic nodules. Not surprising, actually, in this region of the respiratory tract. You would expect to find numerous lymphatic nodules. Let's talk for just a minute or two about the cleaning mechanisms and the conducting airways. So we're talking about the cleaning mechanisms in the larynx, the trachea, and the bronchi. Now, the respiratory epithelium combined with mixed gland secretions provide the primary cleaning mechanism. Imagine the cilia beating are going to move particulate matter away from the respiratory tract. The mixed gland secretions are going to provide a mucus coating. This mucus coating is going to trap bacteria and dust particles. The synchronous beating of the cilia is going to move that mucus towards the esophagus from the regions below the oropharynx, and obviously from the regions above the oropharynx it's going to move it towards the esophagus as well. Glandular secretion is controlled by hormones and nervous innervation. The glandular secretions contain mucus, but there are serous components to these secretions. These serous components contain various antibacterial substances like lysozyme, IgA, peroxidase, lactoferrin. They also contain secretory leukocyte protease inhibitors. As you're going to understand, when there's immune reactions going on in the respiratory tract, a lot of neutrophils are going to migrate into perhaps phagocytized bacteria. As those neutrophils die and get degraded, they're going to release granules, and the content of those granules needs to be degraded. And that's some of the functions of this secretory leukocyte protease inhibitor. There are also alpha-1 protease inhibitors that are secreted by the liver that are important in neutralizing neutrophil proteases. And you're going to come to understand that there's got to be a fine balance. The neutrophil proteases get released to control bacterial infections, but if you have a massive infection and you release too many of these neutrophil protease granules, then you could potentially damage the respiratory tract, and we'll talk about that later. That actually has some very important clinical significance. Here's a region of the trachea in front of the esophagus. You'll remember this from gross anatomy. You can see the mucosal surface, the respiratory epithelium, the submucosa. Here are some of the cartilage that would support the trachea. And this is kind of an interesting slide because it shows some of this cartilage which is actually transformed into bone. This transformation actually does occur in aged individuals. Here's just a general histological view of the tracheal epithelium, the respiratory epithelium. You can note scattered goblet cells, but you can also note intraepithelial clusters of goblet cells. These would be intraepithelial glands, as well as the submucosal glands. And here's just a electron micrograph of the epithelial surface. You can see the profiles of the cilia on these pseudostratified columnar cells, and you can see the goblet cells full of their secretory granules, and then some of the basal cells. These basal cells, of course, give rise to the epithelial cells. Here's just a histological view of the trachea and primary bronchi. It's difficult to distinguish between trachea and primary bronchi, and for our course we'll assume the primary bronchi are those regions of the bronchi that are outside of the lungs. On an exam, we'll take either trachea or primary bronchi for an answer. You can see here by scanning electron microscopy the ciliated epithelium and the goblet cells, and just a little bit higher power view on the bottom. Higher power view in the histological level, you can see the fairly thick basal lamina, which is rich in elastic fibers, the submucosal glands, and some of the hyaline cartilage. Here we have some secondary or tertiary bronchi. And how do we know they're secondary and or tertiary bronchi? Well, we know that because you can see lung parenchyma. You can see the massive amounts of alveoli. So if you have a bronchus structure within the lung, we're going to consider it a secondary or tertiary bronchus and would accept either answer on a practical exam. Very characteristic of the bronchi, you can see the cartilage plates. You can see it here in a little bit higher magnification, and you can see the smooth muscle associated with these cartilage plates. So you can see that here. You can see some profiles of smooth muscle here. Oftentimes you can see some lymphatic nodules associated with these bronchi. Remember, we used the term bronchiolar associated lymphatic tissue earlier in the course. Cleaning mechanisms for the conducting airways, these would be the bronchioles. The bronchioles are lined by ciliated simple columnar or cuboidal cells. Goblet cells and mixed glands with cartilage are absent in the bronchioles, but there's a new cell type that appears in the bronchioles that's called a Clara cell. The Clara cell is a non-ciliated bronchiolar cell. The Clara cell secretes a secretory product. It's a thinner mucus type product compared to what's secreted in the upper airways in the respiratory tract. The secretory product here, the main one, is called Clara cell secretory product, CC16. You don't have to remember CC16, but this product is secreted to protect the airways. It consists of lipoproteins, has detoxifying substances in it. The proportion of Clara cells increases as the diameter of the airways decrease. Clearly, bacteria and dust particles adhere to the bronchiolar fluid, and the cilia are going to sweep that fluid up to the upper regions of the respiratory tract towards the oral pharynx. The viscosity of the bronchiolar cell secretory product is lower than that of the mucus of the upper airways, and thus this fluid easily moved by the cilia in these narrower conducting passages. Here we see a histological view of a bronchiole. Note the epithelium, note this smooth muscle but no cartilage plates. Higher magnification, you can see the ciliated cells. These are a lower cuboidal cell, maybe a short columnar cell, but they tend to be a simple epithelium. Here you can see a profile of the Clara cell or the bronchiolar cell. Here in scanning electron microscopy, you can see the ciliated cells and the non-ciliated Clara cells. The terminal bronchioles are the last portion of the conducting airways, and the terminal bronchioles give rise to structures called the respiratory bronchioles. And then from the respiratory bronchioles, you get the alveolar ducts, alveolar sacs, and the actual alveolar air spaces. Now, the difference between the terminal bronchiole, which is a conducting passage, and the respiratory bronchiole, which is the first respiratory component, the respiratory bronchioles have walls of alveoli as part of their structure, and we'll talk about that a little bit later. Here's just a scanning electron micrograph of one of these terminal bronchioles, and you can see the Clara cells as well as the ciliated cells. And remember, as you get deeper and deeper into the conducting portions of the respiratory tract, especially to this level of the terminal bronchioles, you have way more Clara cells than ciliated cells, and that's highlighted in the scanning electron micrograph. Here is just a view of one of the Clara cells. It's a typical protein secretory cell, so lots of rough ER, Golgi, and then particles that are budding off of the Golgi containing these secretory products, and this is secreted by constitutive secretion. Couple of notes: the cross-sectional area of all of the terminal bronchioles combined is something like 2,000 times the cross-sectional area of the trachea. So the volume of mucus that's moved might be expected to overwhelm the tracheal lumen. However, some interesting points. The ciliated cells comprise maybe 15% of the epithelium of the terminal bronchioles, but the ciliated cells comprise something like 53% of the epithelial cells in the trachea. So even though there's a lot of mucus that's going to be moving up from the terminal bronchioles towards the trachea, there are many more ciliated cells in the trachea that can move that mucus away. Also, the rate of beat and the length of the tracheal cilia far exceeds that of the cilia in the smaller airways. There are also some neuroepithelial bodies, perhaps consisting of clusters of brush cells, that might be present within the epithelium of the conducting airways, especially at their branch points deeper in the conducting portions of the respiratory tract. These cell clusters are innervated, they may represent oxygen sensors, and they may actually secrete serotonin.